Hi everyone. So today we'll be discussing breastfeeding and food allergies. This is something we see a lot in our practice, and we're excited to get to share with you what we do every day. So first off, I'm sure everybody in here knows, but breast milk varies from one woman to another throughout the day, depending on the length of feeds and the time of day of the feeds, and depending on how long mom has been nursing, and then based on mom's diet. So a few examples of how mom's diet may affect breast milk. For the first example, vitamin B12, it is found in animal food products. As far as infants store this B12 in the liver while developing in the womb, and they have about as much to basically live off of that, what they've stored in the liver in the womb, for about 4 months, and then they start depending on mom's amounts of B12 from her milk. And mom actually could get that from, like I said, animal proteins. Maternal levels can be affected by a few things. So nutritional deficiencies, this could be from a vegan diet if they aren't supplementing B12 very well, or poor nutrition just in general, not a very well-balanced diet. It can also be determined just based on maternal malabsorption. So if mom has had a history of gastric bypass surgery, or if she has intestinal inflammation or surgery history, or if she has pernicious anemia as well. And then if the baby ends up being deficient, they could end up having hypotonia, weakness, failure to thrive, and or recurrent infections. Another example of how mom's diet may affect baby is vitamin D. So this is found in dairy products and can also be absorbed from the sun exposure that mom gets and baby gets. A study by Hollis and Associates found that vitamin D content of breast milk can actually be increased by maternal vitamin D intake and or solar exposure of mom. The study comparing breastfed infants' levels of vitamin D. So group 1, mother and infant, were each supplemented with 400 IU of vitamin D per day daily. And then group 2 is moms that had breastfed infants. They were supplemented with 6,400 IU of vitamin D per day, and the infants were not actually supplemented at all with vitamin D. And they actually found that there was no difference in the laboratory values between these two groups. So by supplementing mom's diet with high amounts of vitamin D, they actually had no change. So we didn't actually have to supplement the infant's diet. So we know that breast milk can be very influential in developing the microbiome and the immune system of an infant, but research is fairly conflicted so far about the effect that it has on allergy development. Scientists are currently involved in studies to try to determine what effect breastfeeding may have on allergies. But a few of the important ingredients in breast milk for developing the microbiome are human milk oligosaccharides, Secretory Immunoglobulin A, or SIGA, and cytokines. So HMOs, what they are a type of carbohydrate found in the breast milk. They are actually the third most abundant carbohydrate, or third most solid component of breast milk, secondary to lactose and lipids. They are synthesized in the mammary glands, and the amount in human milk actually depends on mom's genetics, her environmental exposures, and what stage of lactation that she's in. And it's a very hot topic in research nowadays. Scientists have determined that they are so important, they're trying to figure out alternatives for use in infant formulas, such as galacto and fructo oligosaccharides as well. So there's a really important, this is a really important factor in developing babies and their immune systems. So what they do, they are minimally digested in the GI tract. So they can actually make it, once baby is taking in that breast milk, they can actually make it all the way to the colon without being digested. But once little pieces of them can be digested into the colon, and then they can pass through onto the blood and the urine. There's actually some studies that have found HMOs in the blood and the urine of infants. But a few of the things that they can do for infants is that they can prevent infection by supporting immunity. So some of those HMOs that make it down to the blood and the urine, they can actually, one study found that it may reduce infection of E. coli by making the ureter cell walls more resistant to that E. coli. A few more examples that some studies have found is that it prevents binding of pathogens to cell walls of the intestinal tract. So they act as what's called soluble decoy receptors to help prevent these pathogens from binding. So this means that the pathogens actually get into the digestive tract. They mistake those HMOs for what they're supposed to be binding to in the digestive tract, and then they excrete the body, like from the body, with those HMOs instead of being absorbed and causing illness or infection. And then another study suggests they may actually have an effect on nose and throat microbiota. So this may help be one of those factors that decreases respiratory infections in breastfed infants. They also have an influence, like I said, in the gut microbiota colonization and development in newborns. So HMO actually, they act as a prebiotic, so especially for things like bifidobacterium, which is a very important probiotic in the body. So they help to multiply the bacteria that are required to activate the immune system. And some probiotics, such as bifidobacterium, can actually help to increase the IgA secretion, which is what we're going to talk about next. So it really does come full circle. So secretory immunoglobulin A. So it's one of the antibodies that's made by the immune system. It's located throughout the body, but especially in the respiratory and the gastrointestinal tract. It's present in both breast milk and the gut. It's actually created in the mammary glands by cells that have actually migrated from mom's gut cells. So they migrate up to mammary glands and are produced there. Infants are actually able to create their own protective levels of IgA for the first 30 days, but then their levels start to decline, so they start to rely on mom's milk. They're not able to create. But the highest levels are in the colostrum, which makes sense since they aren't able to create that until about 30 days. So mom's levels in her colostrum actually help baby to become immune. It helps prevent inappropriate immune responses. So that's what a lot of these antibodies do in the body. They reinforce the protective cell layers of the body, and they specifically help to fight substances that would trigger an immune response that are found in mom's environment. So mom's environment really does play a factor in the IgA that she is producing. Low levels may be associated with risk for development of allergies and other autoimmune disorders, supposedly through some studies. And lower levels have been found in some studies of colostrum in allergic mothers and mothers with infants who actually end up going on to develop cow's milk protein allergy. Cytokines is the last ingredient that we are going to be talking about. So what they are small proteins. They actually help cells communicate with each other and can affect how cells around them behave. So I can't tell how big the picture is, but hopefully you can see that there's a stimulus that will actually stimulate this one cell that's a cytokine producing cell, and then the little pink pieces actually floating to the next cell are the cytokines being released from one cell to trigger a response in the neighboring cell, so they can affect how other cells around them behave. They appear to aid in the IgA production, so a lot of things end up liking to help IgA produce a little bit more. And then the most common cytokine in breast milk is actually found to be anti-inflammatory, and larger amounts of these have been found in breastfed infants versus formula-fed infants through some studies. We still do have a lot left to learn. There's a lot to be determined regarding the connection between breastfeeding and allergies. But right now, all of us in this room, we agree that breast is best, so it really is important to know what to do when baby shows signs of allergy development while breastfeeding. So we're going to go through a case study really quick before we delve into some of the details of our education. So we actually had a 4-month-old male present to GI clinic with poor weight gain and anal bleeding. The stools tested positive for blood, but parents couldn't see actual blood in the stools. The baby was on an acid suppression medication, and they were receiving exclusively breast milk. Mom was actually pumping. She was no longer direct breastfeeding, but baby was not receiving any formula at this time. So we saw this baby about 12 days after mom cut out dairy in her diet, but she continued to breastfeed through. And then we encouraged mom to continue eliminating dairy, and we reviewed the dairy avoidance handout that we have with mom So even if a mom comes to us and she's been eliminating dairy for a while, we still want to go through that handout because dairy kind of weasels its way into a lot of things that we wouldn't really anticipate it to be in. So there's a lot of processed foods that dairy ends up in that mom might say, oh yeah, I've cut out dairy, and a lot of people are only thinking the typical like milk, yogurt, cheese, etc. But they might be eating muffins that have dairy in it. So we really want to delve into all of those with mom too and make sure she's got everything eliminated. And then along with that, in this dietitian visit, we encourage mom to continue to feed every 3 to 4 hours for baby. And we also fortified the milk with alimentum powder. So we didn't put baby on formula itself, but we just fortified it a little bit. So a very, very tiny amount of alimentum powder mixed in with her breast milk to bump up the calories. That way baby could actually, it could help his growth a little bit because he was suffering from some poor weight gain because of all the stooling that he was doing. And then mom also had 700 bags of frozen pumped milk. So a lot of times moms ask us, do we need to get rid of this? Is this something we need to donate? But we don't really want them to do that at all yet. So there's a high chance that a lot of times babies will outgrow this. So we want them to have something good to be able to reintroduce that with and trial it. So we'll actually encourage moms to keep that. That way we can have them trial that breast milk at a later date. So we'll have them label their breast milk that it contains dairy. And then once that elimination, they've started an elimination period, which Karen will talk about in a little bit, then we'll have them label that it doesn't contain dairy, and then they can start knowing which is which as far as in their milk supply. So we don't want them to throw it out, absolutely not. So now that you can see what would happen in a dietitian visit for cow's milk allergy, Karen's going to speak a little bit more in depth about what exactly cow's milk allergy is and give more specifics about the education that we would provide to mom.
Thanks, Kirsten. Can you guys hear me okay? Awesome. Okay, so Kirsten's giving us a great overview of some of the key ingredients that are found in breast milk that are potentially protective against food allergy development. But let's talk a little bit about the food allergies themselves. So we all know that the rate of incidence of food allergy in children and infants is increasing substantially. You may have heard by now, I'm sure, of the hygiene hypothesis. So this is the thought that infants are being born into such a clean and sterile environment that the wrong kind of bacteria, the bad bacteria, is what is cultivating their gut and altering their long-term microbiota, like Kirsten mentioned, versus more natural ways to get into this world, such as vaginal deliveries and breastfeeding. And so those are going to help babies culture the right kind of protective good bacteria to help build a stronger microbiome. Every GI conference we've gone to for the last 3 to 5 years talks in detail about the microbiome. And I think it's a fascinating topic that you guys, I'm sure you've, just a quick show of hands, who's heard of the microbiome? Yeah, so I think 5-10 years from now, we'll know so much more about how this impacts things like autoimmune disease, not just food allergies, but things like asthma, things like eczema, type 1 diabetes, celiac disease, inflammatory bowel disease. It's all on the rise. And so I think 5 or 10 years from now, we'll know a lot more than we do now. But for now, our job is to counsel those mothers and fathers of children who are diagnosed with food allergies on how to successfully avoid those potential allergens. And so what I'd like to talk about, Kirsten alluded to, is one of the most common that we see when we're talking about breastfed infants, and that is a milk allergy. So to clarify further what I am talking about here, cow's milk protein allergy versus a lactose intolerance. It's important to note that a true food allergy that's causing an inflammatory response within the body is a reaction to the protein itself. Okay, so a protein allergy is causing a reaction. And when you're looking at the literature, you'll see different terms describing this reaction. It could be a food-induced allergic disorder, allergic colitis, allergic proctitis, proctocolitis, all these different variations of what we're describing as a protein allergy. There are other types of protein allergies like anaphylaxis and something called FPIES, food protein-induced enterocolitis syndrome. These are very rare in breastfed infants. We don't often see an infant have anaphylaxis due to milk. And so these would be a different type of reaction. So the first part are what we're going to focus on today. But I wanted to differentiate that between a lactose intolerance. Lactose is often blamed as causing a milk allergy. I'm allergic to lactose. I don't tolerate it. When lactose itself is actually a carbohydrate. So remember, not a protein. And so we see so many people in our practice that say, I can't do milk. I'm sure being at WIC, some of you might interact with parents that are on formula at some point. My baby can't have milk, I need soy. We are milk intolerant. And so that could vary based on anyone that you ask what that means. Some people say, well, I can eat cheese, but I can't drink milk. And for adults, it's true. We tend to have a decreased level of lactase, which is the enzyme that breaks down lactose as we age. So we might not tolerate things the same as we used to. But when we're talking about infants, a true congenital lactose intolerance is very rare. And so we wouldn't expect to see that same sort of lactose intolerance, with the exception of slightly decreased lactase enzyme levels after something like a GI illness. But it's not really going to be like, I have a milk intolerance, so I need soy, okay? All right, did it switch? Yeah, okay. So when we're talking about that protein reaction, there's two main types that we'll see. So an Ige mediated response or a non-Ige or cell-mediated response. So the Ige means an immediate reaction. So this would be something that you would see within minutes to maybe a few hours after an infant would consume the product. So you would expect to see some pretty significant reactions, such as vomiting, wheezing, difficulty breathing, a skin rash, swelling of the lips or eyelids, or even in older children, not infants, but anaphylaxis. Whereas non-Ige mediated or cell-mediated responses look more delayed. So this could be a couple hours after consuming the protein, or even sometimes several days. So it gets to be a little bit trickier when we're trying to sort through these. But these symptoms might also be a little calmer as well. We might see things like chronic regurgitation or reflux, abdominal pain, which sometimes can be assumed to be colic. We might see diarrhea, sometimes with protein loss or blood loss. Sometimes we'll see constipation, perianal rash, failure to thrive, poor weight gain, occult blood loss, or sometimes even iron deficiency anemia. So not that immediate reaction, but this long-term effect of that inflammatory response in the gut. And it is possible that an infant could have a reaction to both types. So you might see the vomiting on top of the chronic poor weight gain and bloody stools, okay? So much of the literature for talking about cow's milk protein allergy in breastfeeding infants is more geared towards a specific constellation of these symptoms called proctocolitis. And so this is where we would see the classic presentation, blood and stool. Sometimes infants will also have a rash, but not always. And so this bloody stool comes about as a result to the milk protein passing through mom's milk into the baby's intestines and having that inflammatory response in the rectum or distal sigmoid colon, causing blood loss. Sometimes it can be frank blood where you see it, or as Kirsten mentioned, sometimes parents don't notice that it's happening and it's only detected once a stool sample is taken. Most commonly, this presentation happens between 2 and 6 weeks of age, so pretty little babies that we're talking about here. So as far as what this will do to an infant, that ongoing loss of blood for such a little baby can lead to anemia or loss of protein if it's left untreated. Some pediatricians will, when they suspect something like this, will obtain a hemoglobin and albumin level, so a blood and a protein level for a baseline, to be able to monitor that infant's trend to see if it really is going down or if the baby's doing okay. And in some cases, this inflammatory response over time can lead to poor weight gain, malnutrition. We've seen some pretty sick little kiddos in our GI clinic. And so because growth is an issue, accurate weights and lengths should be measured to help monitor for the infant's Z-score trend. I know WIC does a great job of helping us monitor these kiddos and help letting us know when there's red flags if somebody's fallen off their curve. Okay, so as far as allergy testing, the literature is actually pretty varied on whether they feel like it's accurate and appropriate for testing out for allergies in an infant. But the most recent studies show that it's really not that helpful. There's a lot of false positives and some false negatives. So it's really not very helpful in identifying whether the milk protein allergy is there. But what we do know, and the literature does agree upon, is that when it's suspected to have a cow's milk protein allergy, the first line of treatment is to modify mom's diet. So most of the time, if the infant is growing okay, and we're seeing maybe small amounts of blood in the stool or not really even seeing blood in the stool, and if the lab values are okay, then we do want moms to be continuing breastfeeding while starting on a dairy-free diet. And for some babies, if they are noticing some blood, they might start to see some improvement in the baby's symptoms in as few as 3 or 4 days. So it really can be a quick turnaround for these more mild kiddos. So we would encourage them to follow that diet for at least 14 days. If after that 14-day washout, we don't see any improvement in the baby's stool, they're still having some mild blood in the stool, then it's possible that milk protein wasn't the offending protein and that baby needs to be further evaluated. It could be that further dietary restrictions are necessary, but they should probably, at that point, most certainly be sent to a specialist to evaluate further. However, if that 14-day washout period did help and the symptoms are gone, then what we want to do is reintroduce cow's milk protein into the diet to challenge the diagnosis. Since allergy testing is not consistently universally accepted as helpful, this is the way we know. We take the protein out, we monitor the symptoms, we challenge that protein. And if the symptoms return, we say, okay, yes, this was a cow's milk protein allergy, and mom should be encouraged to follow that milk-free diet for at least 6 months. And for some of those kiddos, we'd suggest to wait until they're 9 to 12 months before reintroducing again. Full disclosure, we have trouble with this piece of the diagnosis in our clinic. As dietitians, we're consulted to do the education, and then unfortunately, we don't get to see them when they come back because they're doing better. So the doctors just say, okay, you're doing great, follow the milk-free diet. So I think it's important to know that that's part of what we should be doing, so you guys can help us too. And we don't want moms to unnecessarily follow a restrictive diet for longer than what they would need to. So that milk protein challenge should occur. The only exception to that would be if the baby did have severe reactions. We wouldn't be wanting to encourage them to do that trial at home without supervision. Okay, and so let's see. A quick note, I know we're talking about breastfeeding, but if that baby is getting any formula at all, whether it be through a supplemental bottle or fortification, like many of our NICU babies end up having to be on for catch-up growth, it's really important that if mom's working her tail off to take dairy out of her diet, we don't want to undo all that by having a formula with milk in it. And so we want to make sure that we're asking those questions when we see them. Are we getting all the milk out of mom's diet? And is there any formula? We need to make sure that that milk is out of there too. So like I alluded to earlier, a lot of times we think, well, if we can't do cow's milk, let's do soy. However, the literature actually shows that there's a high cross-reactivity for children, that if they are having an allergic reaction to cow's milk, that they'll also have an allergic reaction to soy. And so in this instance, it would be appropriate for that baby to be switched to an extensively hydrolyzed formula. So what that means is To give you an example, would be something like Nutramigen, Progestamol, Alimentum. So those milk proteins are broken down so that they are not going to be in a pattern that will cause that inflammatory response. And 90% of infants that have a cow's milk protein allergy will tolerate this extensively hydrolyzed formula just fine. However, there is a 10% documented that even this partial milk breakdown is not good enough. Some babies will require a complete amino acid-based formula. And so these would be things like Elecare, Neocate, Pure Amino. They would be free amino acids, no digestion required, just absorbs without any risk for that inflammation response, okay? Okay, so I wanted to share with you how we help these moms and give you some tips. So when you're supporting our mamas out in the community in the state of Ohio, you can help make sure we're not sneaking anything in. So like Kirsten mentioned, of course, moms realize to avoid the most obvious sources of dairy, such as milk, yogurt, cheese, ice cream, sour cream, and butter. You would not believe how many people I come across in the 11 years I've been doing this that don't realize butter is dairy. I don't get it, but they don't. So helping them make sure they get all the obvious sources first. And then we want to make sure they're also avoiding any potential hidden ingredients too. So like Kirsten mentioned, this could be things like baked goods, creamy salad dressings, cream-based soups, and things like processed meats are even going to be more likely to have casein, which is a milk protein in them. So your hot dogs might have milk in them, and moms may not realize that. So we want to make sure we're teaching them to really look at labels and think about what may be in those foods. We've come a long way with this, so careful label reading is essential to make sure that we're avoiding milk. When I first started as a dietitian, our job was to teach parents to be diligent label readers and ingredient investigators. So they had to comb through the ingredient list and think, are these things indicating milk? What casein, whey, ghee, what are these things that might mean milk? But luckily in 2006, the government helped us out a little bit and passed the Food Allergen Labeling and Consumer Protection Act. And this changed the labeling practice so that things that are considered the top 8 allergens had to be listed on that food label in plain language. So what you'll see now, I'm sure you guys have noticed if you pick up anything that you're eating, you'll see. So on the left would be where it has to say in bold within the text of the ingredient list, milk in plain language, or a statement at the end of the ingredient list that says what it contains. It might be wheat, milk, and soy. So they've really helped us to make that easier for parents and make it a little safer for these mamas to know what they're doing. As far as eliminating an entire food group, as dietitians, we know that could lead to some concern. And so we encourage all of our moms who are breastfeeding to continue taking their prenatal vitamins. So we want to make sure that when moms go dairy-free, they remember to check their prenatal vitamin list for dairy as well, along with any other medications that they might be taking too. It's rare, but possible that dairy could be in one of those. And since milk is a good source of the vitamins and minerals listed here, we are lucky that there are plenty of other options out there for these mothers to get those same good nutrients. And so for calcium and vitamin D, we know these are so important for bone health, especially for women, especially for reproduction, and especially when breastfeeding. And so we're really lucky that nowadays there are a ton of great fortified milk alternative options on the market. Too many to list, but we have a list. I'll show it to you. But these are a great choice for most moms because it can be simply swapped out for cow's milk in their diet. They can also look for calcium-fortified orange juice, fortified oatmeal, breakfast cereals, and other foods like tofu or dark green vegetables. So we do meet moms who aren't the healthiest eaters, and if they don't like any of these things that we've mentioned, then we encourage them to take an additional calcium supplement. So you probably already remember that in order for calcium to be best absorbed, it's better to take it at different times throughout the day. Our body can only do so much at once. And so we would encourage moms to take their prenatal vitamin with their breakfast, their extra calcium with their dinner, and if they're really at risk, maybe a third one with lunch, 500 milligrams of extra calcium. So then as far as the other nutrients, we have meats, legumes, and whole grains to help fulfill those nutrient needs as well. So really encouraging them to try to get a balanced diet and keep their own nutrition on par, especially if it's something that they're going to be following for 9 to 12 months, okay? Oops. Was I on the wrong slide? Sorry. Okay, so we also arm mothers with plenty of other advice. When we were updating our handout, we all took part. Lauren made some dairy-free mac and cheese where she used unflavored almond milk instead of milk, and she used nutritional yeast to help get the cheesy flavor. Kirsten made some apple cinnamon muffins where she swapped out the butter in the recipe for cooking oil, olive oil, or canola oil. And I was able to make some creamy mashed potatoes using, again, the unflavored almond milk and a vegan butter. And so we want to help moms realize that this is doable by giving them as many resources as we can. So other cooking tips, baking tips, and sample menus are things we send them home with. And here's our sheet. I know it's tiny. I can send it to you guys if you'd like, but this is just an example of some of the brand names that are out there. When a mother of a 5-week-old baby is trying to take dairy out of her diet, she doesn't have time to go to the grocery store and stand in front of an area she's never looked at before and start reading all of the labels. So we like to give them specific brand ideas. They do make a dairy-free sour cream. This is what it's called, so you can look for it. These are some samples of dairy-free butter, so you know exactly what to look for at the store. Trying to make it as easy for them as possible. Okay? All right, so switching gears just a little bit. That was all if baby has mild reaction. That's how we want, this is most of the babies that we see. But however, because we work at Nationwide Children's, we see the sickest of the sick. And so sometimes there's infants that are having not just a mild reaction, but a pretty severe reaction. So large amounts of blood in the stool, failure to thrive or severe malnutrition, alarmingly low hemoglobins, and anemia is there. In these cases, the literature does support to get those babies well and keep them out of the hospital. They do recommend putting them on a hydrolyzed formula for that 14-day washout period while mom starts her dairy-free diet. And the ones that are like septic looking go straight to an amino acid-based formula. So we ask our lactation team to help with these situations. It's a big challenge, and so some of these moms have never pumped before, some of these babies have never taken a bottle before, and moms may not know how to appropriately store their milk. So there's a lot of education that must be done to help make sure that this is as smooth of a situation as possible. And so like Kirsten mentioned, we do encourage them once their diet has started to label that breast milk because, again, just like before, once mom does the washout period, we need to challenge and reintroduce the cow's milk to see if that is what was causing the symptoms in the first place. Since growth is such a factor for these kiddos, usually we will have them wait a little longer before starting that trial. We wouldn't get someone feeling better and stop pooping blood and then all of a sudden try to induce it again. So we recommend like at least 2 to 4 weeks after the baby's weight gain is well on track. That's when would be an appropriate time to challenge the diagnosis. And again, if the blood doesn't return, then it might be warranted to look into what else might have been causing this in the first place, or are further dietary restrictions necessary. So if the blood comes back, when mom goes back to breastfeeding on her milk-free diet, we need to figure out, are there other things that might be bothering this kiddo, or is there something else going on altogether? Okay. So in the literature, just like milk and soy have a cross-reactivity for babies and children, it's well published that this may be the case for moms as passing through mom's milk as well. And so if milk alone doesn't cut it, then we would recommend going to milk and soy. Soy is in everything. It makes it really hard. We think like soy milk and tofu, okay, that's easy to avoid, but it's in a lot of processed foods. So we really work with these moms to help make sure they know, again, what to choose. And then the literature, I find this really fascinating. If the baby has not just bloody stools and poor weight gain, but also the atopic dermatitis or rash, for whatever reason, that rash seems to be most likely correlated to an egg allergy. And so then we would maybe ask moms to start milk, soy, and egg. And similarly, even if they were mild, if they had that bad atopic dermatitis, we might go ahead and ask them to avoid egg too. So again, these can be really tricky, but that's why it's important to see a dietitian to make sure these diets are complete. The literature also does support that if these three ingredients don't fix the problem and the rest of their medical workup is coming up normal, that it may be worth talking about doing a full elimination diet. And so my first slide had the top 8 allergens on there. This would be a diet free of the top 8 allergens. So no milk, no soy, no egg, no wheat, no peanut, tree nut, fish, or shellfish. It's not easy, and so we want to make sure that this mom that we're working with is capable and willing and able to do that. It's something we actually do have really good handouts for because we do use that diet for other diagnoses at Children's, such as kids with eosinophilic esophagitis. That's often a treatment option for them. And if any of you are from the Cincinnati area, that's what they offer all their kids. So it's not impossible, it's just not easy. So we want to make sure that we're not just prescribing that willy-nilly, okay? And so just a quick anecdotal story. We will often see moms that come to our clinic that have taken everything out of their diet. Maybe they're only eating 5 things. I think we had one in clinic less than a month ago that was only eating turkey, rice, and cooked veggies. Nothing else. And so I found a very interesting study that showed that the correlation to moms who overdiagnose their child as having food allergies is related to mom's educational background. So the more educated a mom was, the more she was likely to overdiagnose her child as having multiple food allergies. So if you come across a mother who's a smart cookie, but she's only eating 3 things, it might be worth talking about, let's see how we can help you get back to a more balanced diet, because this is not long-term doable for you. This is not healthy for you, and it's probably not healthy for your milk, as far as B12 and vitamin D, like Kirsten mentioned. So we want to help make sure that we're doing this appropriately. It's a big deal that we're asking of these moms. And so when they do require these restrictions, whether it be just milk or a slew of other things, remembering they have a very young baby at home. People are trying to bring them food, and they want to cook for them, and they want to go out to eat, and they don't have time to do anything, barely brush their teeth during the day, and now we're asking them to do all this other stuff too. So it's just really important. I know this room, you guys are the amazing people, I think, about being supportive of moms. So they need that extra hand-holding and support and cheerleading through these big changes. And so, again, what we help our doctors hopefully try to realize is that these diet restrictions can be hard. They can be costly. Some of those vegan butter products are a little more expensive than regular butter, and it requires an awful lot of planning. And so, again, just being there to help arm these mothers with as much information as we can to make it as easy for them as possible is part of why we love our job. Okay, switch gears.
All right, can you guys hear me okay? Yeah? No? Okay, so I'm gonna switch gears on you guys, and we're gonna talk a little bit more about introducing solid foods and using that to prevent food allergy. And we will talk about breastfeeding, or I will talk about breastfeeding a little bit at the end, but I'm really gonna focus on peanut allergy. So Karen kind of already talked about this, but food allergy is on the rise. It affects 2 to 10% of the worldwide population, and then in the United States, it's almost close to doubling. For peanut allergy specifically, over the past 10 years, the prevalence in children in the Western countries has doubled from 1.4 to 3%. It's also becoming a problem in other countries where it wasn't really a problem before, like Africa and Asia. And peanut allergy is also the leading cause of anaphylaxis and death due to food allergy. So it's a big deal, and we want to do what we can to prevent it. So I'm going to kind of review the historical recommendations and guidelines that were in the United States to prevent peanut allergy. So in 2000, the American Academy of Pediatrics recommended that you wait until 3 years of age to introduce peanuts in children who are at high risk for developing allergic disease. And they defined high risk as both parents, a single parent, or a sibling having food allergy. They also recommended that nursing mothers should eliminate peanut from their diet and the other kind of top allergens, so milk, egg, and fish. They also said that pregnant women should consider eliminating peanuts from their diet. So that's pretty different than the guidelines that I'll talk about later. So I thought that was kind of interesting. In 2008, the AAP updated their kind of recommendations. They said that there was no evidence to support maternal dietary restriction of foods during pregnancy or breastfeeding, and there wasn't any evidence to delay the introduction of complementary foods past 4 to 6 months to protect against development of allergic disease in non-high-risk infants. So you would definitely want to introduce those foods. In 2013, the American Academy of Allergy, Asthma, and Immunology released a very similar guideline recommendation to the 2008. And I just thought it was interesting that that was 5 years after, so it just takes a long time for change to kind of come about. There are a lot of studies that have been done to look into early solid food introduction and food allergy prevention. Until about 2005, most of those studies were observational, so there wasn't a lot of power behind them. But all the observational studies suggested that earlier solid food introduction was strongly associated with a lower food allergy risk. So the two main studies that I found regarding peanut allergy, the first one was in 2008 by Dutoit, and it looked at two very similar sized groups of children in school children, Jewish school children, one in the UK and one in Israel. And they were given a questionnaire to determine peanut allergy prevalence and the relationship between peanut consumption during infancy. So based on the results of those questionnaires, they found that there was a higher incidence of peanut allergy in the UK children compared to the Israeli children, so 1.85% versus the 1.7%, and that was statistically significant. And then they also found that peanut was introduced earlier and eaten more frequently in Israel versus the UK. A later study in 2011 by Johnson et al., they looked at 594 infant mother pairs from the general population. It was like a longitudinal birth study, and they looked at the relationship between early food introduction and food sensitization. And they found that there was a decreased peanut sensitization with complementary food introduction before 4 months of age, which is pretty early. The most compelling evidence, though, for early peanut introduction came in 2015 with the Learning Early About Peanut study, or the LEAP study. So hopefully some of you have heard of that study before. This was a big key study because it was a randomized control trial. So I'm going to spend a little bit of time talking about that study because that's where all of our recommendations come today. So the LEAP study was a single-center, open-label, randomized control study. They were looking at the number of participants with peanut allergy at 5 years of age. So the inclusion criteria were you had to be between 4 and 11 months of age, have either severe eczema, egg allergy, or both severe eczema and egg allergy. So severe eczema was self-defined. So you either had to have like frequent use of topical steroids or parents describing just a really bad rash. And then egg allergy was defined as a skin prick test with 6 millimeters or larger reaction on the arm if you didn't have egg ingestion. And if the infant had egg, then the size of the reaction was 3 millimeters. Those two were considered egg allergy. So they enrolled 640 infants in the study. There was a screening. Everyone had to do a screening peanut allergy skin prick test. So there were 2 groups based on the results of that test. So the first group, they didn't have any measurable, they call it a wheal, which is the raised bump if you have an allergic reaction. So if you didn't have any measurable bump, then you were put into one group. And if the wheal was 1 to 4 millimeters, you were put into the second group. If it was greater than 4 millimeters, it was assumed you would probably have a peanut allergy and you weren't allowed to participate in the study. So after that initial skin prick test, the groups were then put into each group was separated into two other groups. So the first group, infants were instructed to consume dietary peanut until they were 5 years of age. And then the second group, they were instructed to avoid eating any peanut at all until 5 years of age. So in the group that was advised to consume dietary peanut, they wanted them to eat 6 grams of peanut protein split across 3 or more meals per week. So the preferred source for this particular study was Bamba. I don't know if you guys have heard of those at all. It's like a peanut puff, basically. They're really popular in the Middle East, and I have seen them in the stores here now, so they are becoming a little more popular here. So infants were advised to either eat the Bamba, or if they didn't like the Bamba, then they were allowed to have smooth peanut butter. So there was another option. So at 5 years of age, they looked at the prevalence of peanut allergy. So in that group that had the negative skin prick test, which was a much larger group than the one with the positive test, they found that in the group that avoided peanut, 13.7 had peanut allergy, and in the group that consumed peanut, only 1.9% had a peanut allergy. So that was found to be statistically significant. And then in the group who had a 1 to 4 millimeter reaction from the skin prick test, 35.3% who avoided peanuts had a peanut allergy, and 10% who consumed peanuts had a peanut allergy. So it's pretty compelling evidence that decreased peanut allergy with peanut introduction between 4 to 11 months of age, there's a decreased frequency in the development of peanut allergy. So after the end of that study, they decided they wanted to study the kids further. So they did the Leap On trial. So at the end of the primary trial, all of the participants, which regardless of what group you were in, were instructed to avoid peanuts for 12 months. So they wanted to look at if early peanut introduction would have a protective effect if peanut was avoided from the diet. And they looked at the number of participants with a peanut allergy after that 12 months, so when they were 6 years old. So at 6 years of age, all the infants that were advised to avoid peanut, the prevalence of peanut allergy was 18.6%. And then in the peanut consumption group, the prevalence of peanut allergy was about 5%. So I think, and that was also statistically significant. So there is a protective effect to early peanut introduction. If you consume peanut for the first 5 years of life and then don't, you probably have a low likelihood of developing a peanut allergy. So I'm going to go back a little bit in time before the LEAP study was released. So in 2010, the National Institute of Allergy and Infectious Disease released guidelines for the diagnosis and management of food allergy in the United States. They did not provide any strategies for how to prevent peanut allergy because there just weren't good studies. But they did say that there's insufficient evidence for delaying introduction of solid foods and potentially allergenic foods beyond 4 to 6 months. So in 2017, after the LEAP study, which was released in 2015, they released an addendum to their guidelines, and this is kind of what we use now for how to introduce peanuts in infants, and all of their recommendations were based on the results of the LEAP trial. So there were kind of 3 separate little addendums based on the category of infants. So for those high-risk infants, and they defined it the same as they did in the LEAP study, so either having severe eczema, egg allergy, or both, they recommend that you should introduce peanuts as early as 4 to 6 months of age. You should probably consider an in-office evaluation for peanut sensitization. And they laid out some specific guidelines for what to do for oral challenge of peanut based on your skin prick test results. For infants with moderate to mild eczema, they recommend introducing peanuts around 6 months of age, and you don't need to have an in-office evaluation. And in infants that didn't have any eczema or who don't have any eczema or food allergy, you would want to introduce peanut when it's age appropriate. So introduce normal solid food and then work peanut into that. This table kind of just summarizes what I just said. So it splits up the different infant criteria and the recommendations for when you would want to introduce peanut and how that should be done. And this, I wanted to throw some pictures in, so it was in all studies, but this is just a diagram for the high-risk infants and what you should do. They have recommendations for Ige testing, which is kind of what Kirsten was talking about, and then the skin prick testing, so, and what you should do for how to introduce peanuts. So these guidelines, they recognize that infants that were enrolled in the LEAP study were 4 to 11 months of age, and they still benefited from peanut consumption regardless of their age of entry. So even if an infant misses that 4 to 6 month window and they're considered to be high risk, there's still likely a benefit to introducing peanut. So a reason they might miss that is if there's developmental delay or anything like that. So you would still probably want to introduce peanut even if they missed that little window. For introducing peanut, they recommend 4 different recipes, and the recipes are the same for if you were to introduce peanut at home versus in an office setting. So the first recipe would be to do peanut puffs, those bombas I was talking about. The recommended amount of peanut protein they want kids to have is 2 grams of peanut protein. So that's the equivalent of 21 pieces of bamba, or 21 little puffs. So in infants less than 4 months, they recommend softening that with some water. And for older infants who can handle dissolvable textures, it's okay to just give the plain puffs. The next recipe is a thinned, smooth peanut butter. So you would take 2 teaspoons of peanut butter and gradually add some hot water to it. 2 teaspoons of peanut butter has 2 grams of peanut protein. You would want to let it cool, obviously, before feeding it to the infant. The third recipe is a smooth peanut butter. So again, 2 teaspoons, but you would mix it into a previously tolerated puree that the infant has had, and that's another way you can feed the peanut butter. And then the last is to use a peanut flour or peanut butter powder, so like the PB2, if you guys know what that is. So you would do 2 teaspoons of that, add it into 2 tablespoons of a previously tolerated puree, and that would be the whole recipe that you would want to feed. Since I'm a dietitian, I had to put up some nutrition information about these things. So I wanted to just kind of give you what like a typical serving size of all of these things would be considered as, and the number of calories in a serving. So for bamba, we want, again, the 21 puffs is what would contain 2 grams of peanut protein, and that's the desired amount that should be offered. A typical serving size is 1 bag, so that's like about an ounce. And then into 21 sticks or puffs, that has 93 calories. So peanut butter, the 2 teaspoons is the desired amount to have 2 grams of protein. They say a typical serving size is about like a tablespoon on some bread or toast, and that would have about 59 calories. Peanuts, which would not be recommended at all for infants or toddlers, but they have it here just for comparison. So to get 2 grams of peanut protein, that would be 10 whole peanuts. And that would be 45 calories. And then the peanut flour and peanut butter powder, there's not really a typical serving size for that, and they're pretty low calorie too. They're only 13 to 15 calories per the 2 teaspoons. So how do you introduce this? You want to start with a small portion of that recipe. So they recommend that you introduce the whole serving of that recipe. So you would start with the tip of a teaspoon, wait 10 minutes. If there's no reaction, then you would continue to gradually feed that whole recipe until it's gone. And then you would want to observe the infant for at least 30 minutes after to watch for signs of allergic reaction. So this is probably really small, you probably can't read it, but this is what we give infants when we see them at in clinic. If they ask about how to introduce peanut, we recommend doing the smooth peanut butter thinned with water. There's a nice YouTube video that's by the American College. I'm not going to show it to you because it's a little bit long, but by the American College of Allergy, Asthma, and Immunology. So if you guys want, I can send this out, but it shows how to mix the peanut butter and what the right consistency is, so that can be helpful for families also. So some other considerations just in regards to early introduction of solids that directly contradicts the recommendations of the WHO and the AAP to direct breastfeed exclusively for the first 6 months of life. I think it's important to remember that those recommendations were designed to enhance other outcomes, so to prevent or to reduce infant morbidity and reduce GI and respiratory tract infections. So that recommendation isn't about preventing food allergies. So that's just something to think about. And then in those guidelines I was talking about, they recognize that it departs from the recommendation to exclusively breastfeed until 6 months of age. But the LEAP study did look at the effect of early introduction of peanuts, and they didn't really notice, or there wasn't any effect on the duration or frequency of breastfeeding, which is good, and it didn't really influence or impact negatively growth or nutrition. So even though it contradicts the other recommendations for breastfeeding, it's still likely okay to do. And there aren't a lot of studies that look at early solid food introduction and the duration of breastfeeding, but the data that is out there suggests that it does not impact total breastfeeding duration. This is kind of just a random study that I found that I thought was interesting and that you guys might find interesting too. So it was just published this year, and it was looking at data from a 1995 Canadian study. Part of that study, they collected information on breastfeeding and maternal and infant peanut consumption. Those were all captured in questionnaires. So they found that 58.2% of mothers consume peanuts while breastfeeding, and 22.5% of those moms directly introduced peanuts to infants by 12 months of age. And then they looked at those kids at 7 years of age, and 9.4% of them were sensitized to peanuts. The lowest incidence of that, which was 1.7%, was observed in those kids whose mothers consumed peanuts while breastfeeding and also directly introduced peanuts before 12 months of age. The incidence was significantly higher in mothers who consumed peanuts while breastfeeding, but they did not introduce peanuts before 12 months of age. So that was 15.1%. And then mothers who avoided peanuts and then also did not introduce, but directly introduced peanuts by 12 months of age, the incidence of peanut sensitization was about 18%. So I think that's just interesting that there seems to be, in this study at least, that it can maybe pass through the breast milk. So I thought that was interesting. And that's all we have for you guys. Do you guys have any questions? Yeah.
Child or their mother in another, like to a dietitian, like a specialist. A lot of kids come in or moms come in and say, oh yeah, my doctor says it might be an allergy, and so they just immediately switch over. At what point should we encourage them to seek a specialist as opposed to a pediatrician or a family physician?
I think since you're asking 3 dietitians, we'd say send them all. If you're looking at the big picture and you feel like mom says, well, yeah, I've taken out milk, but I found this almond milk that I really like if they can anecdotally seem as though they've compensated for it, then they're probably doing okay. But if it's something they're going to be doing long term, that could do a lot of damage to their bone density if they eliminate, for milk, for example, an entire food group for that long of a time. So I think sending them to a dietitian if they're willing to go and they feel like they need help, I think that would be a great idea. Definitely if they're eliminating more than one food group, I think, for sure.
I think it's sorry, just to add on to that, I think it's a slippery slope to a lot of, like you were saying, those kind of more educated moms. They just start taking like literally everything out of their diet, and so I think if the earlier we can catch them, the better, so that we can encourage them to reintroduce some of those foods too.
Yeah, that's what I was actually going to say. The example that Karen gave, the like poultry, rice, and cooked vegetables, I actually saw 2 moms in the past probably 3 weeks that had gotten down their diet probably to like very minimal amounts of foods. So it was all about like, how do we increase your diet and make sure you're well nourished so baby is also well nourished. So yeah, I agree with Karen. I would like to see them all, but yeah, whenever you feel like mom is either taking it a step too far, that could hinder her or baby's nutrition levels.
So I had a quick question for the kiddos who you're doing the 14-day washout, and then they're actually doing the Alimentum or straight to Elecare. What are you guys doing? Because you said, yeah, go back to straight to, at breastfeeding. What are you guys doing? Because I feel like the baby's going to get really confused going on full bottles for 14 days, not even going to know what to do. So what do you guys do with those babies to keep them in tune with what they need to be doing at the breast?
Yeah, it's definitely a struggle. It's not our favorite part of the practice. I would say that a lot of times by the time they get to GI clinic and then by the time they get to us, they've been told by their pediatrician already to start fortifying, or your baby's not growing. So a lot of times they have had bottle introduction, and a lot of times that kind of helps. Since I am part of our lactation team now, I could see where we might be able to introduce some non-nutritive breastfeedings, where we do that in our NICU a lot, maybe having mom pump first and then give the formula, allow the baby to come to the breast. There's no guarantee they're not going to get that protein, but I think it depends on the severity of the baby's illness too. But you're right, it's not our favorite part by any means.
I have a friend who is so sensitive to dairy that, she can't even do butter. But she can do goat's milk and goat's cheese. What do you know about that or its use?
So I think that's really interesting that she does tolerate them, because the proteins for goat's milk, sheep's milk, and cow's milk are all very similar. So similar that we wouldn't recommend a toddler who had a cow's milk allergy to drink goat's milk. So I think that's pretty unique. And perhaps if it's been a lifelong thing, perhaps it's an accommodation that her body has made. But I find that surprising. Just started. Yeah, that's interesting.
So when you're having your moms reintroduce their dairy after the 14-day washout, how are they introducing it? Like, how do you have them do it at first? Is it something that's complete dairy, or is it baked in dairy? Is there a certain way that you do that first?
So that's a great question, and there's, it sounds like you've seen the new article. There's some really cool articles coming out about baked milk, where children or people with milk allergy can start to acquire tolerance through baked milk. And so we don't have the sophistication in our clinics yet to encourage moms in this instance to do that. So we would have them trial probably that day 1 pumped milk that has the most cow's milk in it. Or if mom was feeding through, which is most of them do, we would encourage her to try a day, maybe a full serving, 8 ounces of milk, a whole cup of yogurt, cheese on a sandwich, and monitor from there. I haven't seen any specific, like the peanut was very specific grams. I haven't seen anything that specific in the literature.
Go for it.
Hi, so my godson goes to your guys' GI specialist in Children's Hospital, and I just had a couple questions while you guys were here. So he was exclusively breastfed for about 3 months, and then he had some colic and constipation problems, and his pediatrician advised her to put juice in his bottle around 3 months old and to start solids early. Do you guys think that contributes at all to GI problems, starting solids early?
When we were talking about the microbiome, I think it definitely does. So there are some really cool studies that look at infants' gut microbiome from 0 to 6 months, and the bacterial changes in their gut are very similar during that time. And then after complementary foods are started, they're all over the place and allowing for introduction of who knows what from our foods, right? The processed foods we're eating, juice, things like that. I think it definitely impacts the overall health of that baby's microbiome. And we hear that all the time, right? I'm sure you guys do too, right? So often, starting foods to help them sleep at night, juice for constipation. But if we can preserve that nothing but breast milk for the first 6 months, I really feel like the studies support that that's giving that baby a really strong microbiome. And I also think that 5 to 10 years from now, we'll know even more than we do now about that.
I had another quick question too. So from what I understood, and I just wanted to touch base, and maybe you're not the ones to answer this, maybe another breastfeeding expert, but from what I understood, when we eat something, especially dairy, I heard there's like a 12-hour delay from the time we actually eat it to when we absorb it to when it's available in the milk. Is that kind of, I don't know if you know or if somebody else.
I don't know that I read a specific time. I know that the literature was varied on how quickly we would see improvement, and the literature was also varied on how long it suggests moms stay, like how long that it would take for it to be out of mom's system. So I think some of the studies I read showed sooner than 14 days, and some of the older ones said even longer than that. So I don't feel confident about an exact number. Okay, thank you guys so
Thanks, yeah.
much.